For this video, we will focus on pharmacologic options for dementia, and dementia is defined as a set of symptoms that include progressive impairments in memory, cognition, behavior, and others. And these symptoms begin to surface and progress following some sort of brain damage due to a variety of etiologies. Now, you can imagine that the location of the damage or injury will help dictate the set of symptoms the patient will experience, and if one of the causes of dementia preferentially alters or causes an imbalance in one population of neurons over others, the neurotransmitter system affected will also dictate the patient's symptoms. So the four main neurotransmitters we are just going to briefly review will be acetylcholine and glutamate. And then to a lesser degree, we will discuss serotonin and dopamine. And this will make more sense in just a minute. So just a brief refresher of neurotransmitters. Now, acetylcholine is a key neurotransmitter that plays a role in memory and cognition, which will be important when we get into the different causes of dementia. So normally, if you remember from the myasthenia gravis video, we have the release of acetylcholine from our presynaptic cholinergic neurons that can then bind our postsynaptic muscarinic or nicotinic acetylcholine receptors. In this case, we have our nicotinic acetylcholine receptors, which once bound allows the influx of cations like sodium and calcium to appropriately propagate signals necessary for learning and thought. And remember, we have those acetylcholine esterase enzymes ready to break down acetylcholine when the signals need to be terminated. Today, we are also going to discuss glutamate, which we discussed a lot in the ALS video. And this is our excitatory neurotransmitter that when released can bind ionotropic receptors as well, like the NMDA receptor, leading to this influx of cations like calcium to help propagate signals. Now on to serotonin, which is a neurotransmitter we will talk a lot about in the context of mood regulation. So a serotonin, once released, can bind the serotonin receptors, acting as a mood stabilizer. And then to terminate the signal, remember we have those reuptake transporters for serotonin to recycle that neurotransmitter, which we talked about in the peripheral neuropathy video. And then lastly, we have dopamine released to bind to our D1 or D2-like receptors to not only regulate motor function, like in the Parkinson's disease video, but also regulate the reward pathways. And these will influence judgment and behavior. So now, what are the causes of dementia that lead to imbalances in these neurotransmitters that give us the symptoms stereotypical of each type of dementia? So the four general subtypes we will compare and contrast are Alzheimer's disease, which I'll abbreviate as AD. We have frontotemporal dementia, or FTD. We have Lewy body dementia, which you also might see as dementia with Lewy bodies. And then we also have vascular dementia. So we will start with Alzheimer's disease because it is the most common subtype of dementia and is characterized by two pathological brain lesions. The first is amyloid beta plaques, which result from the inappropriate processing of amyloid precursor proteins, which is usually processed into protein fragments that do not form these aggregates. The second are neurofibrillary tangles, or NFTs, which are formed from inappropriately hyperphosphorylated tau protein, which is normally just a helper protein for microtubules. So these pathological protein aggregates are thought to disrupt neuronal communication and cause inflammation, eventually leading to neuronal death. And this brings us to another characteristic of Alzheimer's disease, which is a loss of cholinergic neurons in certain brain regions, with this loss of acetylcholine along with disrupted signaling leading to memory and cognitive impairment. And this progressively worsens over time. So another neurotransmitter thought to contribute to Alzheimer's disease is glutamate, and it is thought to similarly lead to excessive signaling that leads to that excitotoxicity that we discussed for ALS. So together, these all come together to lead to Alzheimer's disease. So that's Alzheimer's disease. What about FTD, which encompasses a number of dementias with frontal or temporal lobe degeneration. And a number of these also have some protein aggregate or inclusion body made of tau or other proteins interfering with neuronal function and causing damage. But unlike Alzheimer's disease and acetylcholine, FTD really doesn't have a specific neurotransmitter deficit or imbalance that has been pinpointed. So now Lewy body dementia or dementia with Lewy bodies also involve a protein aggregate issue. This time there is an accumulation of misfolded alpha-synuclein, which normally helps with vesicular transport. So this leads to a similar downstream neuronal damage, but again, a not so much targeted loss of acetylcholine. And then lastly, we have vascular dementia, which would result following stroke, or TIA, for example, leading to an ischemic injury, and location again would dictate symptoms. Now, before we move on, I do want to point out that regardless of the type of dementia we're talking about, it's very possible that the patient may also present with complaints of depression, or some of the symptoms of dementia are confused with depression, which would be caused from an imbalance in serotonin levels in the brain. They may also present with complaints of hallucinations, as well as these sort of judgment and behavioral changes as well, and this would be due to imbalances in dopamine, which is why this will be important when we start talking about our pharmacologic options later on. So moving to our next slide. The reason we went over these different neurotransmitters and the different subtypes of dementia and their key contributors is to provide some context before diving into the therapeutics, which are going to be applicable to only one or some kinds of dementia and not others. And understanding their mechanism and applying it to the pathophys will help you put these pieces together. So we're going to start off by just mentioning an agent that is straightforward mechanistically, but controversial, and that is the monoclonal antibody, aducanumab, which is a targeted antibody against the pathologic amyloid plaques, thought to play a role in the pathology of Alzheimer's disease. So this agent was approved following an accelerated approval in 2021, despite questions of benefit versus risk in Alzheimer's patients. So we won't spend any more time on this agent, but I did want to mention it here in case you were interested to look into the story behind this agent and just so you are aware of it. Now, refocusing back on our neurotransmitters, so we know that acetylcholine is a key neurotransmitter involved in memory and cognition, and especially in Alzheimer's disease, where there is a relative loss of cholinergic signaling. So if we can supplement what has been lost, we may be able to slow that decline and have some degree of symptom improvement. And one way we can do this is by using reversible acetylcholine esterase inhibitors, like donepezil, rivastigmine, and galantamine, which will inhibit acetylcholine esterase, just like we discussed for myasthenia gravis, leading to higher acetylcholine levels sticking around for longer to propagate these neuronal signals needed for learning and thought. So most of these are approved for Alzheimer's disease. Some are used off-label for vascular dementia and dementia with Lewy bodies, but they have not been shown to be effective for FTD. So in addition to its activity at the acetylcholine esterase enzymes, galantamine also binds to nicotinic acetylcholine receptors at an allosteric site to potentiate acetylcholine effects. At those receptors to promote signaling or further acetylcholine release. So based on their mechanism of action, the primary concern with these agents will be cholinergic toxicity. So again, that dumbbells mnemonic. But now really thinking about this in the context of patients with dementia that may be of advanced age. Next up, we will shift to focus on the excitatory glutamate signaling that can contribute to neuronal loss, especially in Alzheimer's disease. And this is where memantine comes in, which is an NMDA receptor antagonist. So it will bind with very high affinity to lead to prolonged blockade of that cation channel, preventing that calcium influx and that downstream excitotoxicity. Again, really just for Alzheimer's disease, where some benefit has been observed and can be combined with acetylcholine esterase inhibitors or used for those who cannot tolerate those acetylcholine esterase inhibitors. So generally, this agent is well tolerated with some GI side effects, headache, dizziness, and some confusion. So now from the slide, I hope you can appreciate that all of the agents we discussed are really targeted at the pathophysiologic mechanism behind Alzheimer's disease and have some degree of demonstrated benefit for these particular patients. Some of the agents, like the acetylcholinesterase inhibitors, may be used for some other dementia subtypes, mostly off-label with variable, if any, established efficacy. So what are the other options for those patients with dementias that do not respond to acetylcholinesterase inhibitors, or when acetylcholine or glutamate targeted therapies have no established benefit, like an FTD? So moving to our next slide. So the remaining options are also symptomatic treatments affecting our two remaining neurotransmitters we have not yet discussed. So for those with dementia and mood or behavioral changes, things like depression, agitation, and anxiety are common, and this is where serotonergic signaling plays a key role. And this is where we can use our SSRIs or our selective serotonin reuptake inhibitors, which have a very similar mechanism of action as the SNRIs that we talked about for peripheral neuropathy, but now we are only inhibiting the serotonin reuptake transporter specifically. So this will lead to increased serotonin levels in the synapse, and over time this will lead to chronic neurotransmitter level changes and receptor regulation to help provide mood and behavioral stabilization. So here I just want to introduce the mechanism of action, and later this block we will dive into these agents in more depth and their use as antidepressants. So now one important point, even though we don't want to dive into the side effects here, is these agents are relatively safer in patients with dementia than our next group of agents, which are going to be our antipsychotics, which, remember from our EPS video, act as dopamine receptor antagonists. Now, there are typical and atypical antipsychotics, which we will save this discussion for a later video, but the key point here is that these agents will bind the dopamine receptor to block dopamine binding and then try to promote balance in dopamine signaling in those with dementia and behavioral changes like aggression and agitation that does not respond to SSRIs. Now, the use of these agents in a patient with dementia really needs to be weighed carefully and try to reserve it for safety-related behaviors that do not respond to other treatments, because there is an increased risk of mortality due to cerebrovascular events in elderly patients with dementia, and this is a black box warning. So in addition to this risk, there is still a risk of those motor side effects that we talked about in that EPS video, which this population may be more susceptible to at baseline. Now, each of these drug classes we will get into in much more depth in later videos, but they can potentially come into play to treat dementia symptoms, especially for those subtypes that will not benefit from altering acetylcholine or glutamate signaling. So moving to our summary slide. So this concludes our brief overview of dementia treatment options, most of which we have either discussed already or introduced briefly in other videos. Now, I hope you can appreciate that most of the agents on the slide are either indicated primarily for Alzheimer's disease and repurposed for other subtypes, or are drug classes used for other primary indications like depression and agitation, but can be helpful for dementia symptoms that overlap with these conditions. Also, I hope I've highlighted why certain agents make sense for certain dementia subtypes based on their mechanism of action, and for those agents that we discussed, their adverse drug reaction profile. Think about how these ADRs might affect the aging population and how this may impact your counseling approach.